All right, got it. So it's my absolute pleasure today to get to introduce Dr. Kate Fitzgerald. Her research focuses on epidemiologic research that integrates genetic, clinical, environmental, and community level data to understand what factors impact prognosis in people with neurologic disease. Most studies involve conducting secondary data analysis of clinical trial and observational cohorts to identify predictors of disease outcomes in people with MS. She also does work with us in HIV. And her analyses really integrate genetic and other omic techniques, as well as derivation of new biomarkers from wearable or digital devices. And I should say, she's been at Hopkins. I've known you since you were a postdoc, and then ended up joining postdoc in neurology, became an assistant professor, and now she's an associate professor of neurology and epidemiology here at Hopkins. She's amazing to work with, and we're excited to hear her speak today. So I'm going to hand the baton over to you, Kate.
All right. Thank you. So can everybody see my slides? All right. Okay, let me move this video down. Okay, everybody. So I'm super excited to be here today. Not going to talk about HIV, but I think a lot of these kind of concepts and measures are applicable more broadly across kind of changes, and especially in the context of aging and HIV. So specifically today, I'm going to talk about leveraging wearable technology for disability monitoring in neurological conditions, and mostly as it applies to multiple sclerosis or MS. So as an outline, we're just going to go briefly over MS, kind of what it is, who gets it, some of the current outcome measures applied in MS research, and kind of maybe what, how they have some less than ideal properties. And then we'll characterize the development of new digital, like wearable-based biomarkers of MS using activity, and then extend these digital biomarkers to more fine motor movements in MS using upper limb function. So MS is an inflammatory neurodegenerative disease of the central nervous system. So kind of characteristic MS lesions on the brain and the spinal cord. So these kind of white dots here. And then it's kind of hard to see, but I believe the lesion is like right there on the spinal cord. It affects nearly 1 million people in the US. It has a typical onset of ages 20 to 40, with about 5% occurring before age 18. And then this is the age and sex distribution of people living with MS in the US. As you can see, MS is more common in women, and the peak prevalence is around 45 to 60. And so the most recent study estimated prevalence a couple different ways, and the left is the lower estimate, while the right is the higher estimate, and they both more or less follow the same kind of pattern. And so MS is the top cause of non-traumatic disability in young adults. So who gets MS? So there's both a genetic and an environmental component. So there's over 200 genetic variants that have been linked to MS risk. And the strongest, most impactful one is variation in the human leukocyte antigen encoded major histocompatibility, or the MHC region, which is kind of the autoimmune risk region. So specifically HLA-DRB 1501 is the top, most strongly, has the biggest effect size for MS risk. With respect to the environmental component, EBV infection, so early life infection with EBV, inadequate vitamin D status, smoking, obesity, especially early in life, and then there's been potential for adverse exposure to certain environmental conditions. So MS has several different subtypes, and so most people start out with what's called relapsing remitting MS, or at least start out with this phenotype where they have relapses or intermittent bouts of disease activity. And approximately 50% of the people who start out with this kind of phenotype transition to what's called secondary progressive MS, where the relapses kind of become less common and disability accumulates more frequently. So a small portion of patients, around 10%, have what's called primary progressive MS, where they have very few relapses throughout the course of their kind of diseases. but they primarily accumulate disability. So most notably, like of the 25 kind of or so approved treatments for MS, my apologies, they all primarily target this relapsing portion of the disease as opposed to, sorry, I have a 2-year-old who gives me all of his diseases. They all primarily target the relapsing portion of MS. And so then I think it's really important to note, and this will come into play later on in the talk, that MS severity is highly heterogeneous with respect to the number and frequency of attacks, the location of the attacks within the CNS, the severity and recovery, the response to MS therapies, as well as the time to reach various stages of disability. So basically how this graph evolves on an individual level is quite heterogeneous. And so most of the rest of the talk will kind of focus on how we can best measure how this picture plays out from an endpoint standpoint. And then just to emphasize again, there are a lot of drugs that are relevant to this phase of the disease and not really any therapies that are meaningful at like the progressive kind of disability accumulation phase that are outside the context of inflammation. And so this is basically, so how do we measure kind of outcomes in MS? And so in the context of a phase 2 trial, typically what's common is the white spots on the brain. So the focal areas of inflammation called lesions. And I think, and then in progressive MS, the common phase 2 trial outcome is brain atrophy. And then in the context of a phase 3, and so, then just to emphasize that there are like, again, a lot of drugs that impact this relapsing. And I think like a big, or maybe a contributor to this has to do with the fact that the new lesions are a good surrogate for the clinical outcome that's applied in the phase 3 trials, which is relapse. And they can be measured reliably and they happen relatively quickly. So short term, like because phase 2 trials tend to be of short duration. At least in MS. And so they happen, so they are a detectable event, and they correlate with the clinical outcomes. Brain atrophy is a little bit harder to measure. It happens more slowly. It's a little bit less reliably identified. And then, so there's no real kind of good surrogate phase 2 for the phase 3 trial outcome. So common phase 3 trial outcomes are the regulatory standard is what's called the Expanded Disability Status Scale, or the EDSS, which I'm going to talk about a little bit more. Or there's kind of a functional composite test, which is basically 3 separate neurologic or neuroperformance tests, which include the 25-foot walking speed, 9-hole peg test, or the symbol digit modalities test. This formerly was, so a test of processing speed. This formerly was the PASAT, but has been kind of supplemented with the SDMT now. And so the EDSS, or the Expanded Disability Status Scale, is the regulatory standard from the FDA perspective. It's based off of the neurologic exam, and then is it ranges from 0 to 10, where 0 is no disability and 10 is death due to MS. And so the EDSS has a lot of kind of concerns and like features that make it not the super best, like most like powerful like outcome for like a clinical trial. First, it's semi-quantitative, it's nonlinear, which has like kind of down and has all these features that kind of have a lot of downstream, not so great consequences. So these features tend to impact its reliability and also this responsiveness, which then translates to larger sample size or longer term follow-up for clinical trials. And then this, of course, causes the higher costs for the trial and then complicates, of course, drug development because you need a lot of money to initiate a phase 3 trial in the context of MS. It also has complications for the definition of who's eligible for trials in the context of like a progressive MS phase 3 trial, just because the individual may have suspected worsening, but still does not meet eligibility criteria because they haven't demonstrated kind of like explicit worsening on exam, which can because it's so variable, presents kind of a concern. And so why might a wearable biomarker be kind of something that would be relevant to kind of disability outcomes in MS? So they're objective, real-world capturing of activity or circadian rhythm and sleep. And so this is kind of things like a Fitbit or accelerometer when I talk about wearable biomarkers. They're pretty low cost relative to kind of an MRI, right? An accelerometer you can use multiple times. An MRI costs at least $1,000, or most commonly like $1,000 to do. And then they also can provide kind of short-term continuous seeing monitors for days to weeks, which can reveal within day variability and small longitudinal shifts that kind of a clinic visit may miss. So maybe help kind of identify those individuals who meet criteria for progressive MS, but kind of the EDSS doesn't miss. And then it has the potential to detect early subclinical worsening before changes appear on this conventional scale. And so far, most of the current studies in MS have been from cross-sectional studies. So this includes a systematic review and a cohort study that kind of used a bunch of different devices that span both from research-grade accelerometers to commercial devices. And they definitely kind of show consistent findings that this is an acceptable technology for people with MS, so people are willing to wear these things and reliably wear them. So if you ask them to wear, the people do it. And they generally found that people with MS perform less physical activity and accrue more sedentary time than their kind of age-matched counterparts, like a little bit as you would expect. They also found that activity is reduced and sedentary. The reduction in activity and the increase in sedentary time both correlate with greater disability. And so opposite directions with EDSS and the functional measures. And so this plot here is basically showing that like activity tends to be physical activity measured using a wearable device is lower in people with MS. And this plot is this is the number of valid weeks that a person, so they asked the person to wear the device, and then you can see kind of they had way more valid weeks than not valid weeks. So the little tiny bars are the number of valid weeks. And so the larger one is 4 versus 3, 2, and 1 here. Then I just wanted to take a quick moment to discuss some of the distinguishing features of two kind of different types of wearable devices and the context here. So there's the research grade device, which is like the actigraph accelerometer, something like most commonly or commonly used. And so this basically detects acceleration in 3 orthogonal planes, which are kind of depicted here. And it's used for actigraphy, which is a measure of physical activity. And what's nice about these things is that raw data is available directly. Other commonly applied devices include like the commercial device like a Fitbit. And so it's quite common that the raw accelerometry data from the device is not available, and there's a proprietary algorithm to measure step count, which is fine, I think, but I think that there's definite concern, at least if you want to use this in the context of a trial outcome, that they don't tell you what how they're measuring the step count. So if this changes during the course of your trial, that's going to be a problem. It's a nice feature of these is that a lot of them just come with heart rate, whereas our experience with the actigraphs, we've just been using the one that are the raw accelerometers. So it'd be nice to also complement these findings with things using the heart rate, and also participants like them. At least in our experience, the Fitbits are a lot more nicer for people to wear, as opposed to kind of the actigraph devices, which look kind of like a little bit like a very large watch. And so what do we know about kind of current studies of wearables in MS using kind of the disability or using the actigraph? And so this is data from our original study, which we had found that first that differences in overall activity summed over a course of the 24-hour period, those are correlated with disability outcomes, so consistent with kind of that systematic review and broad thing. And then I think it's important that we also found that the consideration of the time of the day, so when the person is active, that was actually more strongly correlated with EDSS. And so what you can see here is that the difference in these bars is basically the level of disability. So the black bar is no disability, and then the dark blue is the higher levels of disability. And then what's plotted here is the R squared value. So it's basically, you can see that there's quite a difference in the R squared. So the amount of like variability in EDSS explained by the accelerometry is much higher for certain times of the day relative to other times of the day. And then this black line is if you consider the sum of activity over a 24-hour period. Okay, and then so with respect to longitudinal studies, there's been some. I think there's been one or two. It's limited, but these have been relatively informative. For this study here, 95 people with MS, they found that a decrease in daily steps over a 1 year period predicted worsening in clinical outcomes. So based on the 10, 25-foot walk, timed up and go, and then worse PROs outcomes. And what they found was I think this is interesting, they found a decline in the daily step count. So they used the Fitbit in this study, and they found that a decline in daily step count was observed even in the people who had a stable EDSS score, suggesting that perhaps these were measuring something that that's being missed with respect to the clinical disability scales. And so in summary, kind of some early implication is that cross-sectional evidence supports the construct validity of the wearable measures versus disability. And then early longitudinal results suggest that declining steps may be an early warning sign of functional deterioration in MS. However, some key gaps emerge, I think are quite kind of obvious, is that there aren't any studies linking the wearable devices to the current kind of phase 2 imaging type of outcomes in this context. Very few of the longitudinal studies, or none of the longitudinal studies, considered kind of variation in times of day. So is there changes occurring? Like, are there specific times of the day where reductions in activity kind of correlate more with the outcomes? And then also consideration of individual level effects. So when you model these, this can more succinctly measure that's more of a precision medicine approach, which can enable precision monitoring and early intervention beyond kind of that population average. And so kind of our general hypothesis in initiating this work was that can accelerometry predict EDSS measured worsening before it occurs? So basically, can we detect that a person is getting worse before they're measured, before they meet this kind of clinical trial or clinically defined disability measured, like on exam? And so the underlying hypothesis we had for this study was that accelerometers might be able to detect or more sooner detect these disability changes. So the gray period here is basically, this is our conceptual model or working conceptual model, where we found basically that we thought that the accelerometry measures would be able to detect it basically as a much sooner time frame than when they would be detected, when that worsening period would be confirmed by the EDSS. So this thus created the HEAL MS study, which Ellen Mowry is the PI for. And so for this study, we enrolled three sets of people with MS. So we included a cohort of individuals with relapsing remitting MS. So these were people with stable kind of inflammatory or kind of stable, not progressive disease phenotype. And we included a group of people with suspected progressive MS. So basically their neurologists thought that they were getting worse, but they technically didn't meet that threshold of having progressive MS that's confirmed, like using the EDSS. So these are people that like we think would be eligible for like a progressive MS trial, but they don't technically meet eligibility criteria. And are still labeled, they still kind of formally carry this relapsing remitting MS label. And then And then most notably, these two cohorts of people, these are matched with respect to age, sex, race, and their disease-modifying therapy or MS drug used. And then the third cohort was the people with progressive MS. So these are people with confirmed like disability worsening in the prior year to the study starting. So this study was kind of designed to mimic a phase 2 trial in this context. So they had participants had structured study visits every 6 months. It was a prospective longitudinal cohort, and we anticipate following people for 4.5 years. And at each kind of every 3 months, we asked participants to wear an actigraph on their non-dominant wrist for 14 days. And they did it, every 6 months, they had a blinded EDSS game or EDSS, a blinded MSFC. So this is kind of mimicking kind of what would happen in a trial. They also had optical coherence tomography, which is retinal structure kind of assessment. Visual acuity testing, they completed PROs and reported menopausal status. And then at baseline and then at year 2, they had a brain MRI with and without contrast, as well as a C-spine MRI. Then I just wanted to go over some of the early results from the study where we were trying to answer really, can the accelerometry predict EDSS measured worsening of function before it actually occurs? Documented by clinical exam. And so for this study, we took all the accelerometry measures that are measured every 3 months on their non-dominant hand for the 14 days. We transformed those into activity counts for a minute level data. We included only days with where the participant wore the device for over 90%. And we used validated algorithms for this, where a non-wear time was defined as an interval at least 90 minutes in which all minute level activity were equal to 0. And so here, a valid day is those in which wear time was over 90%. So they were wearing the device for around 1,300 of the 1,440 minutes in the day. And so for this specific analysis, we averaged the day and minute level activity for each wear period. So they wore it for 14 days, and we basically calculated the average kind of minute level data across that wear period for that 14-day period. And then we restricted individuals to had at least 3 valid wear days for a given wear period. And then we calculated several different types of summary measures that are based on activity as well as kind of sleep and circadian rhythms. And so here, we wanted to focus in based on our kind of prior early work linking that certain times of the day are most informative with respect to disability. So kind of wanted to focus in on the total activity in the 2-hour specific windows. We also calculated measures of physical activity and then measures of kind of activity fragmentation. So the ASTP is basically how many times you transition from being active to sedentary, and then sedentary. The SATP is basically how much you transition from being sedentary to active. And then this here is basically a description of the circadian parameters that we defined. So these included the amplitude, which basically is half the distance between the peak and the trough of activity, the acrophase, which is the maximal activity point in the cycle, and then the mesor, which is the mean value once the cycle oscillates. And these were estimated using extended cosigner models. And then we also included some other view of non-parametric indices. So M10 is the most active 10 hours, L5 is the least active 5 hours. There's a daytime to activity or daytime to nighttime activity ratio, which is DARE. And then IS and IV. IS is how stable your kind of 24-hour periods are, and then how stable your activity is over in a 24-hour period, and then IV is basically how variable it is over that 24-hour period. And so we had kind of these like two big goals of basically what we wanted to do with this kind of first phase of HEAL MS was to basically identify whether and how these accelerometry measures change over follow-up. Then we wanted to characterize how do these changes translate to outcomes using kind of a within-person modeling framework. And so for clinical outcomes, we consider the EDSS, of course, and we considered kind of what's called the EDSS plus, which is a composite outcome encompassing EDSS worsening or 20% worsening in the walking speed or the 9-hole peg test. So it's basically a composite outcome of all the possible clinical trial or regulatory accepted outcomes. And it's supposed to be, I think it's supposed to have more power in detecting kind of disability progression events relative to kind of the individual outcomes alone. And then for the MRI, we wanted to consider changes in total brain volume, gray matter, and thalamic volumes that are occurring over the study. So for this first part, to look at how does each accelerometry measure change over time. So we applied linear mixed effects models that are adjusted for covariates, and then looked basically how does, or we also wanted to check basically, do these changes vary across the different like HEAL MS groups? And then we wanted to look basically, do these changes, like can we detect changes even among people who don't have any type of confirmed disability are worsening over follow-up? And then for the second one, how do these changes in accelerometry measures predict outcomes? So we decomposed each metric into kind of two specific components. So that like overall person-specific mean, and I'll describe this a little bit further, like how we constructed these specific measures. So like kind of a between person effect and then a within person deviation. So this is basically how much is a person's activity changing over the course of follow-up relative to like kind of their average outcome. And so then we wanted to see how these measures related to the disability outcomes. So for the clinical outcomes, we used a Cox model, and then for the MRI outcomes, we've used a linear mixed effects model for adjusted kind of for a similar set of covariates. Then just to describe a little bit more about what these like kind of within person models are. So basically what we took was we calculated if these are basically the person's activity levels at each of the 4 different wear times, we calculated an average of their activity. And these are all of these activity measures, we only considered those that are occurring prior to the EDSS worsening, so prior to like a clinical disability change event. Then we calculated the difference between these overall mean and then their individual kind of person-specific mean, and then transformed this into like kind of a long format data set, which we used for the analysis. So for this study, we included 238 people who are on average around 55 years old. They were 29% male, 23% were non-white. And so with respect to their MS characteristics, they had an average duration of around 13 years and a median disability score of 3. And then 44% were receiving the infusion therapies. So those are kind of the higher efficacy MS medicines. And 1/3 had the clinically defined progressive MS. And so over an average of 3 years of follow-up, we detected 120 EDSS plus, so that composite measure encompassing kind of all of the regulatory approved clinical outcomes occurred. And kind of the participants kind of like they had a disposition kind of as we would expect. So the progressive people had the highest cumulative incidence of disability worsening. This kind of the people with suspected progressive MS, they tended to fall in the middle. And then these, of course, these are all just kind of graphical interpretations, not like statistically significant. And then this dark blue people are the people with relapsing remitting MS. And then we also detected kind of changes in brain volume, deep gray matter, and then thalamic volume that were occurring in this group. So these are kind of, okay, we can detect changes in disability and we can detect MRI outcomes. So I think these are kind of reassuring that like our trial is or our simulation cohort is like behaving as we would expect. And so now transitioning to kind of what the activities profiles look for these two individuals over the course of the day. So as I mentioned, our primary analysis was kind of focusing on the difference in activity over the course of delay and how it relates to the outcomes. And then this is just an activity plot for someone with kind of a low level of disability, and then a person with a high level. And so as you can see, kind of the measures for the person with a higher level of disability, they tend to be lower than, of course, this person with the lower level of disability. So over the course of the study, the participants wore their accelerometers for an average of almost 10 times, which translates to around 90 days of wear over that 3 years of follow-up. So this is kind of a lot of, I thought there was a lot of data. And then an average of 7 of those wears, or 67 total days, occurred prior to any detection of like the clinical disability worsening on an exam. And so what's plotted here are the change in the individual measures over follow-up using data obtained prior to the clinical events. And so these are standardized beta coefficients to allow them to kind of be all on the same scale. And basically what they imply, that measures of overall activity, so total activity and during 2-hour windows, and physical activity, they generally decreased over follow-up. So these are basically, this means these are reducing, or these activity measures, activity during this period is reducing, or is decreasing. And so these are kind of the physical activity tends to decrease over follow-up. So the MBPA or the LIPA. And then as you kind of would expect, the like converse of that, the like day, how often you're kind of your activity kind of is stable, and as well as like sedentary time is also kind of increasing over follow-up. And then what I think is interesting is that these pictures look quite similar. So I can toggle back and forth, and you can see they look pretty similar when we included individuals who had not experienced any kind of clinically defined EDSS worsening, so clinically defined disability progression. And this was basically as our attempt to see if our accelerometry measures could detect subtle changes that may not have manifested as clinical disability yet, so before they would show up on exam. And what I think is they probably can, which is reassuring and kind of consistent with the data that had shown with respect to the Fitbits in that early study. And then when comparing how our accelerometry indices change between the HEAL MS subgroups, the people with progressive MS exhibited kind of more pronounced declines in multiple activity measures. So including total activity, or physical activity, and kind of the time period in which they have their 10 most active hours relative to like relapsing in the suspected cohort. In contrast, increases in sedentary activity and in how variable their days are were most notable in the progressive MS group. And so these kind of patterns generally just suggest greater deterioration in activity and circadian rhythmicity among these individuals with the more progressive phenotypes. So kind of just to summarize, do the accelerometry measures change over time? I think the answer is yes. So we found that they had almost 10 wears for nearly 90 wear days. And then prior to kind of any disability event, there were 7 wears and 67 wear days. So kind of we were phenotyping these people pretty well, I thought. We generally found that activity declined over follow-up, and then sedentary and then activity fragmentation kind of tended to increase, which is consistent kind of with those observations. Total activity declined around 2% per year in this population, and then our results were robust, even and similar when we restricted to participants without any kind of clinical disability worsening. And so now, how do we look at what do these changes mean? So how do these changes translate to clinical outcomes? And so we chose to model the association for a 1 standard deviation decrease in total activity and risk of disability. Just be kind of it's how they were changing over time. So basically, a decrease in activity would translate to we would hypothesize that a decrease in activity would translate to a higher risk of disability. And so these are the within-person results. So again, the hazard ratio is that within-person decrease in activity for a given period of time. How does that translate to outcomes? And we found that in generally, a within-person daytime increase in activity during certain windows of the day. So basically from 8 o'clock until around 2 o'clock. Those were within person. A standard deviation decrease in activity during those windows was predictive of subsequent EDSS worsening. And then I think it's important to note that we didn't detect these significant findings for the total activity, suggesting I think that there's probably meaning in considering kind of the within person results for kind of the within day activity. And so again, these are the results for the between person, so the average effects, so this person's average activity over the course of the day. And we really didn't find anything. These were pretty null, which I think emphasizes the kind of importance and the strength of using kind of modeling these within person effects versus kind of the between or mean level effects. And so for the other activity measures, we found that increases in fragmentation, so a decrease in fragmentation, so less fragmentation was associated with a lower risk of EDSS. Decreases in physical activity, or how the difference between decreases in physical activity were associated with a higher risk of EDSS worsening, which I think is consistent with the kind of total activity counts. And then also kind of a decreases in how different your daytime versus nighttime activities are. That was associated with a higher risk of EDSS. And then the between person means models for this showed generally similar directions for activity and circadian measures, but were not significant. Again, emphasizing kind of the importance of considering these kind of within person models. And so then keeping with our one standard deviation decrease in activity measures, we found that these kind of decreases were also consistent with changes in brain volume. So for example, one standard deviation within person decrease in total activity from 8 a.m. to, which would be these measures, was associated with a 0.2% change in whole brain volume over time, which I think is a notable finding just because this is a relatively short kind of period, and this is a significant or notable changes in both kind of the whole brain volume and the deep gray matter and thalamic volume, just because these kind of are the biggest, strongest correlates with disability progression here. And then for the mean volumes, a higher total on 24-hour activity, as well as a lower mean activity level from during the nighttime, as well as during that daytime period. So in this context, they were kind of consistent across the two. So basically, decreases in activity were associated with lower brain volumes during this kind of time periods. So just to summarize, we found that kind of early day activity was associated with brain volumes for within person models. The patterns were generally consistent across multiple 2-hour windows for kind of the deep gray and the thalamic atrophy, and consistent with kind of the whole brain volume results. For the other circadian measures, we found similar to kind of the clinical disability outcomes, decrease in the DARE, so how different basically decreases in how different your daytime versus nighttime activity were associated with lower gray matter volumes, a decrease in the amplitude, so how much activity. So basically the top part of the DARE ratio. And for this one was associated with worse gray matter volumes as well. And then I think what's interesting here is, so if we exclude anyone who's had disability progression event, so no clinical changes were observed on the exam, and then we refit our models here, so no changes. These people didn't have any type of kind of clinically relevant MS activity, so they didn't have a lesion on their MRI, they didn't have any type of relapse or focal inflammatory event, and they had no disability progression. And what we found was that for the within person models, And for some of the between-person effects that we found that reductions kind of in this morning activity period were associated with lower brain volumes over time. So this is kind of consistent with kind of the broader type of measures. So these are people that you think are stable, but if you're measuring kind of their activity levels using the accelerometers, we're detecting changes here that are related to kind of how their brain is changing over time. And so just to kind of summarize more broadly for this, like the summary measures kind of physical activity here. So we found that within-person changes in real world activity and circadian patterns preceded disability progression and brain atrophy in this cohort. Daytime activity declines and reductions in physical activity. The daytime-nighttime activity ratio were consistently linked to higher clinical worsening and loss of gray and white and thalamic volumes. A lot of times the signals were detectable prior to any kind of clinical exam findings, indicating subclinical changes that could be captured with the wearable devices. And then these findings notably emerged over a relatively short time window. So our follow-up was like 2.9 years. So this is kind of consistent with what would be kind of a phase 2 trial, which also supports the feasibility for using these measures in that context. So I think these has kind of a couple different implications. So mainly one, that longitudinal digital phenotyping with accelerometry that offers a prognostic value and a scalable way to monitor neurologic health benefits between the clinical visit. So with respect to kind of outside the trial context, I think it does still have meanings. And that time of day and circadian features could be considered as candidate endpoints or early warning markers in MS studies and care. And so that was kind of the first kind of phase of HEAL MS. So it was focusing mostly on the kind of these broad activity kind of summary measures. So we included a lot of different ones, but they're still kind of summary measures, and they're mostly focused on like activity and kind of related to walking, to be honest. And then I wanted to highlight too, I wanted to note that it's common that MS trials also exclude people that use a wheelchair exclusively, just because it's really hard to measure changes in disability at this end of the scale. So oftentimes these people are just they're too far gone, which is kind of which is unfortunate. And are excluded from participating. And so what we wanted to see is that in this group of people, or are there other measures that extend beyond kind of physical activity and walking based measures that could be derived from the accelerometry data. And we hypothesized that these kind of micro features based on upper limb function would detect more subtle differences between kind of like MS and disability findings, and they'd be informative for predicting future disability, even among this group where it's traditionally kind of even more challenging to detect changes in disability. So as I said before, we've concentrated on activity summaries that mostly incorporate gait or walking level indices, but motor level impairments extend beyond gait. So MS does also impact upper limb function. So tracking kind of arm and hand movements is also essential kind of for this non-ambulatory group. So for here, we wanted to kind of extend the methods that drive upper limb function that were originally developed in the context of ALS. So basically the number of upper limb movements and the duration of the upper limb movements, and this is kind of how they're derived here. And then this is just a summary of what the upper limb movement digital biomarkers we adapted that were originally developed for MS, and then we applied in or they were originally developed for ALS and applied in our MS cohort. And so I have some basically the daily counts, the number of times they did these upper limb movements, and then the duration, how long each upper limb movement took. And so for this, we considered this forearm flexion and scale. So hopefully my video. So this is an analyst working on our team demonstrating kind of an example movement for this. And this is kind of what the raw acceleration looks like. And then we also considered this forearm pronation and supination, which is this movement here, or similar movements back and forth here. And then this is basically so he's wearing the device and doing the movement, and this is kind of what it looks like when we derive the data from the accelerometer. And so what we wanted to ask was, can we adapt these measures derived in ALS in the context of our HEAL cohort? And how do these measures correlate with overall activity and disability outcomes? And these are kind of preliminary results. I'll just go over them kind of quickly. So can we adapt them? So our first attempt failed miserably. And so this is kind of what it was not expected. This kind of jumbled plot, which is nothing like what this should look like and what it didn't look. And so the data appeared meaningless, and we thought, we were like, oh, well, we can't do this. Then we realized that the ALS paper, they used the same maker of the actor graph. However, the axis orientations differed between each of the washes. And so basically what was the y-axis was the x-axis, and the x-axis was the inverse of the y-axis here. So once we figured that out, which is non-trivial, you'd think like they're the same maker, that would be translate, but it did not. So kudos to that great analyst whose picture was here for figuring this out. And so once we corrected this, we, yes, can derive kind of the as expected pattern of the accelerometry. And then, so to kind of further reassure ourselves, we looked at the correlation between the measures and compared kind of what they looked like for the ALS study. And so kind of these measures here, these two boxes are measuring the same kind of aspects of the curves in MS, and then also in the ALS study, which are comparable values. And then these kind of inverse kind of blue boxes, lower correlation values, are kind of similar or quasi-similar between our study and then also that original ALS study. And so what's plotted on this heat map in general, so is demonstrating, I think, some aspects of construct validity. So the upper limb movement measures for a 45-degree angle. So it's kind of like halfway up in movement for each of the number of movements, and then the duration of the movement types. And so the duration is in the blue values, and then which were inversely associated with the disability measure, or sorry, the duration values were positively associated with the disability measures. So basically, the longer they took to take these do these specific upper limb movements, the more disability they had. And then they were also less likely to basically engage in doing these specific movements. So the more times you did the movements, the less disability you had. So we also noted expected differences across the clinical subgroups. So the progressive MS patients tended to have fewer upper limb movements and then tended to take longer to do the movements. And then this is kind of my last slide. And what I think is cool is that like these angles are continuous measures. So what I've showed before is basically just the 45-degree, but you can consider the whole scope of these kind of differences. And to identify kind of the movements or the measurements that are the most informative. And it also opens you up to considering kind of more functional data analysis methods, which is also kind of our next phase. And so what's plotted here, the angle of movement and how the duration of movements at that angle are associated with EDSS scores after adjusting for total activity. And you can see kind of there is a differences based on the types of movement. So then if we just return to our outline, today we learned a little bit about MS and why the current set of outcome measures might leave some room for improvement. Then we showed basically how some wearable technologies might be able to address some of these gaps, and then discussed results related to sign of changes in overall activity patterns and during specific times of the day and how they relate to outcomes, and then presented some early work. So we're just really starting this upper limb movement thing, upper limb movement and kind of derivation might capture some of how these changes in these measures might capture some of the more fine motor changes in MS, which might be increasingly relevant as a person's disability evolves. So just to summarize again, within-person changes in the real-world activity and circadian patterns preceded disability worsening and brain atrophy. The signals were detected prior to any of the kind of clinical worsening, indicating this is probably like a subclinical or prior to kind of the observed clinical changes. So like if we think back to our original diagram, so we're still in that gray part, not the black part. And so findings emerged over a short time window that supported the kind of feasibility for using these measures in the context of MS clinical trials. And so we also note that in our early studies that accelerometers can use to generate digital biomarkers on upper limb movement, so similar across neurologic diseases. And then some of our initial analyses suggest that these upper limb biomarkers demonstrate construct validity with respect to the clinical and severity measures. These, of course, have a lot of future directions. So we really want to define like what is a meaningful change for these like kind of activity thresholds that's most relevant. Also, if we really want these to be an outcome measure, we need to demonstrate they have responsiveness to intervention. This is quite challenging in MS just because we don't really have therapies for kind of this progressive component. We'd also want to start to apply kind of more complicated statistical models that allow you kind of to model that whole curve rather than kind of individual components, and then link to other kind of measures, including cognition and other imaging measures like linked to physical disability, like the spinal cord cross-sectional area. And then lastly, I'd like to just acknowledge our collaborators, Ellen Mowry, she's the PI of the HEAL MS study. I do most of the data analysis. And then Blake Dewey, who is our imaging guru, who has processed all of the MRI data that I presented here, as well as Murley. I don't have a picture, I need to get one, but he is basically the data analyst extraordinaire who can work with this data very astutely and is very diligent. So that I'm happy to take any questions.
First, Kate, that was an amazing body of work. I mean, I've heard you now speak grand rounds a week or so ago, and now that, I mean, just the abundance and everything that you're doing. Do we want to go to the chat, or do folks want to raise their hand and unmute to have a discussion? Mine is the first question about what my daughter is going to be for Halloween. Pilwa, did you want to?
Oh, yeah, sure. Thank you, Dr. Fitzgerald. I have two questions. One is actually the atrophy, brain neuronal atrophy in brain tissue. So just one short blink idea in my domain is actually currently I'm actually just recently funded in collaboration with Dr. Amanda Brown. So they're focusing on striatum. They're time course data analysis in co-exposure to HIV-1 and psychostimulant substance use disorder. But actually, I have one former local pilot grant, not fully represented in my former institution of University of Michigan and Ann Arbor. There, not multiple sclerosis, but scleroderma, so skin autoimmune disease. Whatever that is, for example, when you have your clinical study projected onto animal model in some complexity, there actually, and also actually I'm doing mathematics and statistics, so geometry kind of wrinkles. So that is very interesting. So with some relevant metrics, if there can be some relevant kind of diagnosis for prospective therapeutic potential that, for example, with autoimmune disease related master regulatory biomarkers, I'm not sure whether I'm exactly accurately recall, but FOX01 or FOXP1, actually, I need to double check, but that recently Nobel Prize in Physiology and Medicine that one representative biomarker, but actually connected one actually intriguing connection to neuronal cytoskeleton among many others, actually related to our neuronal stemness. So microtubule that is within my understanding. So actually that is one open avenue. If you're interested, we can discuss further. Another question is, actually, yeah, there actually you have some data on thalamus, on the integration of those sensing modalities, but actually, and also you address a kind of motor control and gating behavior. So they are sensory motor. So thalamus and striatum, basal ganglia and striatum, when actually there are some reasonable conjugated data that will be very interesting in further rigorous detailed analysis. And that's it. Yep.
No, thank you for, yeah, no, definitely. I think some of the, like, part of the limitation is like, so for this study, we used, the, like these were research paid for by the study grade MRIs, but they were done on the clinical scanner to basically allow us to leverage kind of interim time points in between. So maybe some of the like more detailed kind of very specific structural elements in like we're not going to be able to measure those in this context. But I do agree kind of the like consideration of like other very like relevant brain regions is definitely of interest. We had focused on the thalamus in this context just because in MS it's kind of the like deep gray structure that's impacted the earliest and kind of the most reliably measured over time. So that's why that's the focus here. But thank you for your comments and interest.
And then there's another one, Raha lost her voice. I think she has the same bug that you may have.
Yes, like, our kids are best friends.
Yes. So she just asked, can you expand on other disease applications where we might use digital biomarkers of upper limb movements, what may or may not be MS specific, or rather what would you adapt in aging and HIV applications?
I think like you could adapt very, very similar ones here in the context of HIV or other aging applications. Like I think what was reassuring to us is that like the correlations and at least the relationship between all of the measures were very similar kind of in what we had derived in our MS population and what they were seeing in kind of the ALS. And so we kind of also looked across kind of the spectrum of disability because the people with ALS who they used to develop these, they had with ALS, so they had pretty significant kind of physical limitations. And then we looked at basically how these kind of operated in people without little disability in our MS population, which could be kind of perhaps maybe kind of an accelerated aging phenotype. Those people still had kind of a similar relationship. So I think, I mean, you'd have to test it, of course, right? But I think they'd be like kind of comparable and hopefully useful in that context as well.
We'll have to pull you into the HIV end. We pulled you in for some of it. Does anybody else have any other questions? We're just about at the top of the hour. Okay. Well, thank you, Kate. That was amazing. Caroline, do you want to, I don't know who's speaking next week.
Sure. It's Adam Spira with Johns Hopkins, and his talk is Sleep, Aging, and Brain Health.
Ask him all of your questions about accelerometry and the aging.
Yeah, exactly. Come back next week, Kate.
Yes, no, Adam's great.
Yeah, he's great. So thank you guys, and see you back here next week, same time, same link.
Thanks, guys.
Thank you.